Good evening, everyone. So, welcome back in, in my anatomy shortcut channel. So, today we'll be discussing about the colon. So, if you remember about the colon, so colon is the part of the large intestine, yes, and the large intestine is almost 1.5 meter long, yes. This whole structure, whatever you see, this whole structure is a large intestine, and it basically starts from or extends from the right leg fossa region. Yes, from this region. So if you see here, you can see the ileum. It continues as a cecum here. Yes, and you can also see the appendix. Yes, so cecum. Yes, appendix. So they belongs to the right leg fossa region. Yes, it continues upward as ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. So this whole part, whatever you see here, so this one is a large intestine. Yes, and if you see the measurement of or the length of this large intestine, yes, the longest or the longest part of the large intestine is transverse colon. Yes, if you see this part, this one is a transverse colon. So transverse colon is the longest part, and if you see the shortest part of this large intestine, so here the anal canal region, that is only 3.8 centimeter structure. Yes, so this one is the shortest part of the large intestine. Now, if you move ahead, okay, or if you see, even if you see the extension of this part, so it actually starts right from the right iliac fossa and it ends somewhere here in the perineum region. Okay, so it extends from the right iliac fossa to the perineum region, and the longest part is the transverse colon, and the shortest part is the anal canal. And if you see the extension, yes, so here the small intestine here you will find the lot of coils of the jejunum and ileum, yes. And after that, if you see the ileum, it is entering here into the this region. So this region is called as the cecum. This whole region is called as the cecum. So this junction is called as the ileocecal junction. Okay. So this junction is the ileocecal junction. So the large intestine, it actually extends from the ileocecal junction from this region to the anal canal. Okay. So up to it. So it cecum continues upward as a ascending colon, and after that, this one is a transverse colon. This one is a descending colon, sigmoid colon. This will be the rectum, and here below you will find the anal canal. So it extends from the here, right from the ileocecal junction to the anal canal. And if you see the anal canal, yes, so there are the two lines that are present here in the anal canal. In the upward, if you see here, if you enlarge this part, okay, if you see this one is the interior of the anal canal, and if you enlarge this part, so if you see here, you will find the pectinate line. Yes, so here you will find the pectinate line, and below you will find the white line of Hilton. Okay, so this one is also called the watershed line, and up to here, up to the pectinate line, we call this part as a large intestine. So below the pectinate line, so that will be the another part. Okay, so up to the pectinate line only we call the large intestine. Now if you move ahead, yes, if you move ahead, so large intestine, it has a certain features. Okay, so the three cardinal features are three cardinal features means these are the features that should be present in the large intestine, and they are present in each and every part of the large intestine, and there are some exceptions that we have to remember it. Okay, so the three features are the tinea coli. If you see this structure, can you see this structure? Yes. So this one is a longitudinal muscle band fibers. Yes. So these are the tinea coli. Okay, just remember tinea coli. And if you see this structure, yes, sacculated structure. So this structure is called a sacculated or ostration. Okay, and can you see these fat-filled pouches here? Just in the site of this tinea coli, these are the peritoneal pouches that contains the fat. Okay, so these are called as appendices epiploidy or also called as omental appendices. Okay, and why I have kept this structure of the curtain is because if you remember the length of the large intestine, it is almost 1.5 meter. Yes, it is only 1.5 meter. And if you see here, and the tinea coli, if you see the length of the tinea coli, it is quite smaller compared to that of the length of the large intestine. Okay, so if you consider this cotton as a large intestine and this line as a tinea coli, so to fit this 1.5-meter long structure in this tinea coli or in the what we call elastic fiber, so this cotton they get sacculated. Okay, so such type of structure they are formed, this structure. So such type of structure is called as sacculation, or we also call it as a ostration. Okay, sacculation or ostration. And somewhere here you will find the again you will find the fat filled pouches, and that fat filled pouches is called as appendices diploidy. So this one is the question that they have every time they have asked in the lab examinations. Okay, write the cardinal features of the large intestine. Now, if we move ahead, okay, tinea coli, this one is nothing. So these are the three bands of the muscle. Okay, these are the three bands of the muscle. Those three bands are tinea mesocoli, yes, tinea aumentalis, and tinea libera. So these are the three band muscles. Okay, and these are the longitudinal muscles. They are aggregated and forming the tinea coli. And if you see the length of this tinea coli, it is almost only 4 feet. Okay, 4 feet. And if you see the length of the gut or the large intestine, it is 1.5 meter or it is a 6 feet long. So because of to fit the 6 feet long structure in 4 feet long structure, and there will be the formation of the ostration or sacculation. Okay, so if you just remember the position of these three tinea coli, so tinea libera, they are present here in the anterior surface. Okay, tinea mesocoli, they are present in the posteromedial surface, and tinea oumentalis, they are present in the posterolateral surface. So they are merging here and they are forming the tinea coli. So combinedly we call this whole three structure as a tinea coli. Now, if you trace this tinea coli, okay, it actually starts from right from the base of the appendix, somewhere here from this region. So tinea coli, they are absent in the appendix region, and if you trace this tinea coli, it moves upward to in the ascending colon, yes, in the transverse colon, in descending colon, and if you see here, you will find the tinea coli, and it will reach only up to the this one is a sigmoid colon and this one is a rectum. So somewhere here in this region there is the rectosigmoid junction. So up to the rectosigmoid junction you will find the tinea coli. So right from the appendix to the rectosigmoid junction you will find the tinea coli. And these tinea coli they are absent in the three, especially in the two regions. So one is this appendix. Okay, so one is this appendix. In this appendix you will find there is a absence of the tinea coli, and another one is in the rectum region. Okay, rectum and anal canal region. So there will be the absence of the tinea coli. And to identify this tinea coli, so you can easily identify. Can you see this glittering structure? Yes, glittering structure. This one is a cecum. So here if you see here this glittering structure by, and you can easily identify this longitudinal muscle band fiber tinea coli by the glittering. Okay, so that is absent here in the appendix region. Okay, and you can also identify these fat filled pouches here. So these fat filled pouches, these are all the appendices epiploidy. Okay, and it's quite easy to identify during surgery. Okay, so especially in the surgery of this appendix when you have to remove this appendix part. Okay, so you can easily trace it through the thin ecoli because thin ecoli that is absent in the appendix, so you can do a surgery right from there. So this is the clinical correlation with the appendix. Now, if you see the circulation or ostration, this is nothing. They are the dilatation of the colon. Okay, and appendices epiploidy, these are the fat-filled pouches. Okay, so these are the fat-filled pouches, and they are most numerous. They are present in the transverse and sigmoid colon between the tinea livera and tinea mesocoli. So tinea between the tinea livera and tinea livera and tinea mesocoli. So they are present. Okay. So most numerously they are present here in this two part. Okay. So just remember appendix epiploidy, they are nothing. They are fat-filled pouches of the peritoneum. Now, so you can also observe the disease structures. So these are all the fat-filled pouches. Okay, so appendix epiploidy, they are also present in the every part of the large intestine, and except you will not find this appendix epiploidy in the cecum region. Yes, so somewhere here in this region, in the appendix region, as well as here in the rectum and anal canal region. Okay, so you will not find the appendix epiploidy here in this region. What you will find is this structure in each and every part. Now let's move on to the ascending colon. So ascending colon is nothing. It is an upward extension of the cecum. Yes. So today we'll be discussing about the colon. So because of that, we'll be directly starting from the colon part. Yes. So from this region. So it is almost 12 centimeter to 15 centimeter long structure that actually starts from the cecum region, and it actually ends somewhere here in this region. So this region is this one is a liver. Yes, so because of that, we also call it as a right hepatic flexure, or we also call this part as a right hepatic flexure. We call this part as a right hepatic flexure, especially, or right colic flexure also. Okay, so whether you call it as a right hepatic flexure or right colic flexure, so that is same thing. Okay, so so and this colon ascending colon, this generally lies here in this region. So this region is called as right paracolic gutter. Okay, it lies in the right paracolic gutter and covered by the peritoneum from the front side as well as from the sides. Okay, and posteriorly, if you see here, it actually binds with the posterior abdominal wall. So you can also see here this one is right paracolic gutter. So right paracolic gutter is nothing. It is just a space or gutter that is present just to the lateral side of the uh, ascending colon. So this one is the ascending colon. Now, if you see the posterior surface of the posterior relation of the ascending colon, so ascending colon it will be present here in this region. Yes, so here in this region. So here in this region you will find the ascending colon here in this region. So there are the three muscles and three nerves that are coming in relation, posterior relation with the ascending colon. So what are those three muscles? So if you see here, this one, the first muscle is a, here you can find the quadratus lumborum. Yes, quadratus lumborum first muscle. The second muscle you can see the transverse abdominis muscle, and the third muscle you can find here below. Yes, this one is a iliacus. So because these three muscles they are coming in relation in posteriorly with the ascending colon. Okay, in the ascending colon part. And similarly, if you see here, if you see here, just behind it, there are the three nerves that are also coming in relation. The first nerve is this one. Yes, so this one is a iliohypogastric nerve. Another nerve is a ilioinguinal nerve, and in the lower part you will find the lateral cutaneous nerve of thigh. Okay, so these three nerves, first, second, and third part. Okay, so please remember again when we study about this part, So this region, so this will be again the descending colon. Yes, so again when you discuss this descending colon, again same three muscles and nerve, they are coming in relation in the posterior part, okay, or in the posterior relation. So they will be the same. Now, if you see anteriorly of this ascending colon, yes, ascending colon, so what you will find? So here you will find a lot of coils of jejunum and ileum. They are here in this region, and they are covered by this structure. So this structure is called as greater omentum of the greater omentum, yes, so of the stoma. So right, so anteriorly, so there will be the relation of the coils of the small intestine. When you remove this greater omentum, so you will find again the coils. You can see from below this region also, and greater omentum is coming here in the relation. The second, now sometimes what happens is that if you see swimming colon, suppose you don't have the mesentery of the swimming colon or transverse colon, we call it as a mesocolon. And sometimes what happens is ascending colon is also contains the third mesentery, and that mesentery is called as ascending mesocolon. Yes, and, and, and you know that this greater omentum, it is also covered in this whole area. Yes, this whole area, and the greater omentum gets actually between the covering of the ascending colon sometimes. So here it may get fused. Okay, so this is greater omentum may get fused here, here in this region. So what happens at that time? This transverse colon, okay, the right half of this transverse colon and this ascending colon, they might come very close with each other, okay, they might come very close with each other here in this region, okay, here in this region. So at that time or such condition is called as double barrel gun, okay, double barreled gun. So it looks somewhat like a double barrel gun because the greater omentum, it is coming in contact with the ascending colon. Yes, so they pulled with each other and they form a such type of condition. Okay, so the such condition is called as double barrel gun condition. Okay, and if you remember, so after the completion of this ascending colon, let's move on to the transverse colon. Yes, so this one is a 50 centimeter long structure and mobile part of the large intestine that actually starts from this region. Yes, so this region is called as right colic flexure or also called as right hepatic flexure, and it ends somewhere here in this region. So here you will find the spleen. So because of that, we call it as a splenic flexure or also called as left colic flexure. So this whole structure, yes, the use separate structure. Yes, this one is not a transverse structure. The transverse structure means that should be in the same plane and straight to the body, but you will not find in the straight structure. So it looks somewhat like a loop like U separate structure. Okay, so such structure or this part between the right hepatic flexure or right colic flexure to the left colic flexure or left splenic flexure, so hepatic flexure to splenic flexure. So this structure is called as transverse colon. Okay, and this one is a dependent use separate loop. Now, so we already have discussed that it actually extends from the hepatic flexure to the splenic flexure. So it actually starts from the right hypochondrium and it ends somewhere here in the left hypochondrium region. Okay, so this part, so this structure. So mm, if you let's discuss more about the splenic flexure and colic flexure. Okay, so colic flexure, it actually located here in the right hypochondrium region or right lumbar region. Okay, and this left colic flexure, it is present somewhere here in the left hypochondrium region. Okay, and if you see the level here, so transpyloric vein, so somewhere here you will find the transpyloric vein that passes from the pylorus. Yes, and This right colic flexure, it is present almost 2.5 centimeter below the transpyloric plane, and splenic flexure, that is present a bit higher structure, so it is almost 2.5 centimeter above this transpyloric plane. Okay, so this structure, right colic flexure, it is present at the level of L2, whereas left splenic flexure, it is present at the level of T2. So just remember, so the just above the transpyloric plane, 2.5 centimeter above, you will find the splenic flexure, and 2.5 centimeters below, you will find the hepatic flexure, and splenic flexure is almost present at the level of T12, whereas hepatic flexure is present at the level of L2. Okay, and angulation also, if you see the angulation, it's quite wider. Okay, this hepatic flexure is wider, whereas you will find the angle that is from here is a acute angle in the right left colic flexure. Okay, and you will not find any attachment of the diaphragm in the hepatic flexure, but you will find the attachment of the diaphragm in the splenic flexure. So you have to remember these things. Okay, so a very beautiful structure or photograph of the transverse colon, and let's move ahead. The transverse colon is divided into right two-third part. Okay, right two-third part and left one-third part by the one line. Okay, so this one is an imaginary line. Let's consider this one as an imaginary line because it is mainly related to the development. Okay, so this right two-third part, this is developed from the midgut, and left one-third part, this is developed from the hindgut. Okay, so the development is different. So we have to remember these things. So if the development is different, then the arterial supply of the right two-third part, that is coming from the superior mesenteric artery. Yes, and if it is developed from the hindgut, so there will be the involvement of the inferior mesenteric artery, and their branches are supplying this part. Yes, and superior mesenteric artery and their branches, they are supplying the right side. Okay, so if the arterial supply are different, then the nerve supply will be also different. So the right to third part, that will be supplied by the vagus nerve, and the one third part, that is supplied by the pelvic splanchnic nerve. Yes, and the detail about the development will be discussed more in the development of the GIT very detailedly. And if you remember the descending colon now, so we have completed the transverse colon and ascending colon. Now let's move on to the descending colon. So you know that the descending colon, this one is another longer structure, that is 25 centimeter long structure, and it actually starts from this splenic flexure. Yes, and it moves downward, and here somewhere here in this region you will find the here in this region you will find the left external iliac artery. Okay, so here you will find the external iliac artery. So right from here to here, okay, or the splenic flexure to the front of the left external iliac artery. This whole structure is a ascending colon, and that is 25 centimeter long structure, and this is quite deeply located. Okay, so they are located more in the inner side, very deeply structure, and this descending colon structure, it continues with the sigmoid colon. So this structure here, that will be continuing as a sigmoid colon, and this descending colon, this is also covered by the peritoneum, and in the side you can they are fixed here in this region with the help of left paracollicotor. Okay, and you will also find the iliac fossa here in this region. So they are fixed by the left paracollicotor especially. Now again, we have already discussed that in the right side there will be the involvement of the three muscles and three nerve. Okay, so here if you see here, the proximal part of the structure is it is directed vertically downward from the left colic flexor to the left iliac fossa region. Okay, so somewhere here this region is a left iliac fossa region here, and somewhere here you will find at the T12 level you will find the splenic flexor. So here again in this region there is the descending colon and three muscles and three nerve, they are coming in relation in this part. So those three muscles again showing the left side. So that will be the quadratus lumborum. Yes, quadratus lumborum, transverse abdominis muscles, and you can see here again iliacus muscles and three nerves that are involved: iliohypogastric, ilioinguinal, and somewhere here you can see the lateral cutaneous nerve of thigh. So three nerve and three muscles, they are coming in the posterior relation of the descending colon. Yes. Now, if you see the course and relation of the descending colon in the distal part, in the lower part, yes. So if you see here, somewhere here in this region, somewhere here in this region, okay, this region, okay, it turns first medially, yes, and that is in front of the external iliac vessels here, you can see here, okay. So these are the external iliac vessels, both these are the external iliac vessels, and in the side you can also see the testicular artery and vein, and these two both have a very important clinical relation. Okay, please remember here. So it runs medially in front of the external iliac vessels. Okay, and just side of the external iliac vessels there is a testicular artery and vein, and it passes in front of the, so somewhere here in this region. So again you will find the femoral nerve, genitofemoral nerve, psoas major muscles, testicular vessels, and left external iliac vein. Okay, so here again you will find those relations here in front. So in this figure it's not possible to show all the photo structures. Please remember these things. Okay, so while passing in front, from in front there will be the femoral nerve, genitofemoral nerve, psoas major, testicular vessels, and left external iliac vein. They are present here. Now, so what happens sometimes is that this area, this area, yes, this area, they are loaded with the fecal material here. We know that this area now, these are the loaded with the fecal material. And if we see here, sometimes there are many diseases such as agangliotic megacolonus sponge disease. In such condition, what happens? There will be the there will be the there will be the absence of the peristalsis in this region. Yes. So at that time, what happens if this area they are loaded with the ficus, they might compress this structure. So they are the external iliac vein and arteries and testicular arteries, and then they might be compressing this structure. So because of the compression of this testicular artery and vein, we know that this structure is the left side. Yes, so because of the compression of the left testicular artery and vein, so left varicocele, that is a varicocele, that is a very common in the left side. Okay, so there will be the problem that is associated or because of the absence, because of the problem in the Pempiniform plexus. Yes, so there will be the no venous return. Okay, compression of those Pempiniform plexus or dilatation of Pempiniform plexus, there will be the no venous return. Okay, so because of that, so left varicocele is quite common. So this is also one of the predisposing factors because of the compression of the left testicular artery and vein. So that may cause the left varicocele. Similarly, if you see here the external iliac artery and vein, so these are the in the left side here. So they are actually the main artery and vein that are associated with the left side or left limb, okay, or left lower limb. So compression of any these might cause the problem on the venous return again. So there will be the left lower limb varicose vein. Okay, so it's quite simple and easy way to understand these things. Okay, so because of the sometime because of the loaded fecal material here that may compress these two things that might cause the left varicocele as well as the varicose vein in the left limb, lower limb. Okay, So please remember this thing. This is also one of the very important clinical anatomy. Now let's move on to the sigmoid colon. Okay, so this one is the uh, after passing through the descending colon. So now we move on to the sigmoid colon. Okay, so this one is a S-shaped structure. So it is a S-shaped structure. If you see somewhere here in this region, it looks somewhat like a S shape. Yes, this one is a S-shaped structure and almost 37.5 centimeter long, and that connects the descending colon. This structure descending colon with the rectum. This region. Okay, so connection of the descending colon with the rectum. Okay, descending colon with the rectum and S-shaped structure. And if you see the extension of this structure, so it starts from the lower end of the descending colon, yes, somewhere from here, this region, and so we have not shown this part, okay, the pelvic surface of the third piece of the sacrum. So it reaches up to the pelvic surface of the third piece of the sacrum, and that after that it continues as a rectum. So here, just just behind it, you will find the pelvic surface of the sacrum. So that one is the third piece of the sacrum. And during its course, it forms a sinus loop-like structure. Okay, so this loop is called a sinus loop-like structure, and it hangs freely in the lesser pelvis. So if you see here, so it is hanging freely. Okay, it is hanging freely in the lesser pelvis region. Now let's move on to the arterial supply of the colon. As you know that the right two-third part of the colon, yes, the right two-third part of the colon and left one-third part of the colon, they are developed from the two different parts. So right is developed from the midgut and left is developed from the hindgut. So arterial supply from the right side, that is coming from the midgut, so that will be the supramesenteric artery and their branches, and from the hindgut or in the left side, so that will be coming from the inferior artery, yes, and their branches. So the arteries that are involved in the right two-third part, yes, so they are the colic arteries. So they are the middle colic artery, right colic artery, and ileocolic artery. And in the left side, so that one there is a inferior mesenteric artery and their branches. So that one is a left colic artery, yes, sigmoidal artery, and superior rectal artery. So they are actually supplying this whole region. And sometimes there might be the uh, connection between the superior mesenteric and inferior mesenteric, and that connection is called as arc of Rayleigh. Okay, arc of Rayleigh, and those marginal arteries. Okay, so those marginal arteries that are coming from this middle colic, right colic artery and ileocolic artery. So from the branches of the superior mesenteric or from the branches from the inferior mesenteric. So these branches are called as the marginal arteries. Yes, so these all are the marginal arteries, and these marginal arteries are or also called as the marginal artery of Dortmund. Okay, marginal artery of Dortmund. So anastomosis between the superior and inferior mesenteric artery, and that are then vasa recta. That are these are all the marginal branches. So we also call this as a vasa recta. Yes. So marginal artery of Dortmund, and this whole supply the colon region. And the venous drainage is quite easy. Yes. So they accompanies the artery. So from the same name of the artery, they are draining those areas. Okay, yes, so those areas, and finally they drained here into the portal venous system. Okay, so just remember the artery name. So you can just in place of the artery, you can write the vein, and all these veins, they are draining into the portal vein, directly into the portal vein. Okay, directly into the portal vein. So lymphatic drainage. So there are four lymphatic nodes that are actually supplying the colon. Okay, So they are the epiploic nodes. Yes, epiploic node. Just remember the name only. Paracolic nodes, preterminal nodes, and intermediate colic nodes. Okay, so they are draining the lymphatic drainage by these four nodes. So clinically, these four nodes they are also very important because so when you discuss about the uh, carcinoma of the colon, at that time these four nodes they are involved. Okay, and in any part of the colon, so they can transfer the cancerous substances. Okay, so these four nodes they are involved. Okay, or these four roots they are involved in the carcinoma. So just remember this, the name of this four node only. Okay, and remember the clinical importance that these four lymphatic roots they are involved during the transfer of the carcinoma tissues. Okay, so now let's move on to the clinical anatomies that are associated with the colon. The first one is the diverticulitis. So diverticulitis, before studying the diverticulitis, it is necessary to know about the diverticula. So what do you understand by the diverticula or a diverticulosis? Okay, so diverticulosis is nothing. It is the herniation of the colonic mucosa and submucosa through the muscular wall. Okay, and the inflammation of this diverticula or diverticulosis is called as diverticulitis. So if you see here, this one is a histology of the large intestine or colon. If you see here, this contains the mucosa. Yes, this contains the submucosa, and after that you can see the muscularis externa here in this region. Yes, after that if you see, you can see this layer is called as muscularis mucosa. So this one is a lining epithelium, lamina propria, and muscularis mucosa. So this one is a mucosa, the part of the mucosa, and in submucosa you can see here. Okay, and after that you can see the muscularis externa. So this one is the outpoaching or herniation of these structures. So whatever the structures that are present here in this region that are coming out from this muscular wall, okay, that are coming outside from this muscular wall, and such condition is called as diverticulosis. Okay, and the inflammation of such structures, okay, that which are not those herniated structures that are called as diverticulosis, and inflammation of diverticulosis is called as diverticulitis. So if you can see this structure, this herniated structure. So these are all the diverticulitis. So these are nothing. These are the herniation of the outpoaching of the colonic mucosa and submucosa through the muscular wall, and they are very common in the sigmoid region. Okay, sigmoid region में एकदम धेरै मात्रामा हुन्छ यो. Okay. So when you see in the barium enema, so what you will find? You find that this all the structures here, serrated structure. Okay, so sawtooth-like appearance you will find in the barium enema. So you will see the symptoms of abdominal pain in the lower quadrant, fever, constipation, chill in such cases of the diverticulitis. So another one is a bulbous. So valgus is nothing. Just remember this one is a twisting. Okay, the valgus means twisting of the twisting. Just remember this from twisting. So twisting of the bowel loop is called as valgus. So these are mainly associated with the uh, gut rotation. Okay, so we have not. If you remember the rotation of the gut, so if there is any problem that is associated with the gut rotation at that time, there will be the condition. That condition is called as valgus, and it might occur. This valgus might occur especially in the part of the sigmoid colon because of the extreme mobility that are present in the sigmoid colon region. Is so here in this region. Okay, so sigmoid colon region there is because of the mobility. So this valgus might occur, and this might causes the obstruction of the bowel, and even because of the constriction there might be the loss of the damage of the blood vessels or vascular supply in this region. Okay, So the another term is called, or another clinical anatomy associated with the colon is called as intussusception. Intussusception. Okay. So this is the condition. Okay. This is the another condition where the proximal segment of the bowel. Okay. So if you see here, so this is the proximal segment of the bowel. It gets invagination. It is into distal part. Okay. So intussusception means invagination. Just remember this term, invagination of the one part into the another part, or proximal part into the distal part. Okay, the lumen gets invaginated into the another part of the lumen. So this might causes the cutting off of the blood supply that is present in this region, and that might causes the gangrene. Okay, so please remember intussusception as a invagination. Now the another important, very important clinical anatomy, that is a congenital exanguinonic megacolon. Sometimes we only call it as a megacolon, or we also call it as a Hirschsprung disease. Okay, these are the same thing. To understand this Hirschsprung disease or congenital agangliotic megacolon, we have to remember this structure. Okay, so this one is the histology, again histological structure of the colon. So here you will again find the mucosa, submucosa, everything. Yes. So if you see here, the muscles that are the muscles uh, or the muscle layer that is supplied by the nerve in this region is called as mesenteric plexus, or also called as orbic plexus. And the submucosa layer, they are supplied by the nerve. Okay, so this part, so that nerve plexus that is present in the submucosa layer is called as Meissner plexus. So this megacolon or Hirschsprung disease, these are mainly because occurs because due to the failure of the neuronuclear cell during development. Okay, so it has to reach, neuronuclear cells have to reach in this area, and they have to form this mesenteric and Meissner plexus. So during development or during the migration of this neuronuclear cell, they don't reach in this area. So because of not reaching to this area, there will be the no formation of these two plexes. So this, if there is absence of these two plexes, so whole the peristaltic movement that are occurring here in the colon region, that will be absent. Okay, so because of that, what happens, because of the absence of the peristalsis, so whatever the structures or fecal material they reaches to this region, they accumulated here in this region. Okay, so generally this is congenital exanguinonic megacolon generally occurs in the sigmoid colon and rectum. Okay, so here there will be the, we will find the dilated structure, or even you can say the fecal retention will be occur here in this region. Okay, now another one is a colorectal cancer. So this one is the second only to the lung cancer in the site of specific modality. And if you see here, the colon cancer might occur in the any part of the colon. Okay, any part of the colon, and maximum here in the sigmoid rectum and anal canal region. So this part. Okay, so this part is mainly affected. Okay, even in the cecum also there will be the carcinoma, but it might occur in the any part. And if you see, okay, if you see in the X-ray, okay, so you'll find the apple core like appearance. So this apple core like appearance, this confirms the colorectal cancer. Okay, so please study about this apple core appearance also. Okay, so if you see such type of structure in the barium mill, so at that time this this confirms, or this explains about the colorectal cancer. So especially if you see, because in the United States, Canada, Australia, so you will find the very high prevalence of the colorectal cancer. And you can see, if you see here, it might occur in any every part, they are equally, okay, equally. So if you see here, in each and every part they are in equal in distribution. And one of the main reason of having a colon cancer, especially in this United States, even in India, it's because of due to the high fat diet. Okay, High fat diet is one of the main reasons to have a colorectal cancer. Okay, and another one is Crohn's disease. This one is a inflammatory disease, inflammatory bowel disease. So it might occur in the any part or any segment of the GIT, and especially we see here in the terminal part of the ileum and colon, so they will be occurring. Okay, so that is a Crohn disease. So inflammatory bowel disease is called as Crohn disease. And signs and symptoms of the Crohn disease, you can see the diffuse abdominal pain, diarrhea, fever, and the pain during the sexual intercourses you might see in this Crohn disease. Okay, even the urinary tract infection and malabsorption might occur in this Crohn disease. Ulcerative colitis, next one. So ulcerative colitis means the inflammation of the colon. Yes, so this is also the another uh, uh, clinical anatomy that is associated with the colon. But one of the main important features, if you see here in this ulcerative colitis, okay, so it actually begins in the rectum and it extends proximally upward. Okay, so it after the rectum it may reach to the sigmoid colon, it may reach to the ascending colon, so it moves upward. Okay, and it is mainly limited to those two layers, mucosal and submucosal layers. So this is also the one of the inflammatory disease, ulcerative colitis. And if you see the age group, you can see here 20 to 50 years of age group. Yes, so sign and symptoms you can see arthritis, fever, diarrhea, and abdominal pain, frequently relieved by the defecation. Okay, and in the 80% cases of the rectosigmoid junction, you will find the ulcerative colitis mainly. And thank you so much for listening my lecture, and please subscribe. Thank you so much.